Hello, good evening. Today we are going to discuss together the rest and the second half of discussion about surgical techniques and technology and eMRCS question bank. Okay, we will start from this question. We finished more than half or almost half the question in the first half of the discussion, and now we are going to finish the rest of it. So let's start our discussion. Okay, Dr. Mumtaz, you can start. Dr. Mumtaz, are you ready? Okay, Dr. Abdul Qadir, you will take your turn after Dr. Ali. Okay. Is my voice clear?
Yeah, is that my turn? Hi.
No, we said we'll start with Dr. Mumtaz, Dr.
Okay.
Baida, Dr. Ghada, Dr. Baida, then Dr. Ali, then Dr. Abdul Qadir. I can't see Dr. Mumtaz. You can start if you are ready. I think she's out. She's disconnected. Okay, can go who's next, Dr. Ghada or Dr. Baida? Can I start? Good evening, Dr. Mustafa. Dr. Ghada, okay. Dr. Mumtaz back. Okay, go.
Should I start or wait? Okay.
Yes.
In which electrical surgical modality is the active electrode placed in direct contact with the tissue and is characterized by a low current and high voltage over a broad area? Blunt current, cutting current, coagulation or dissection or coagulation. Direct contact means dissection.
Okay. I think it's easy as we discussed last time. Yes, exactly.
Yes.
Okay. Again, remind you again about what we said last time. Okay. We said, just a minute. Let's keep it up like this. Okay. We said we have two together, cutting and coagulation, dissection and fulguration. Okay. What is the difference? We said go for dissection first. He will tell you the electrode is in direct contact with tissue, and then low current, high voltage. If you have, yes, if you have an ability to understand and keep this information, it's okay. Low current and high voltage, so this is dissection. This is dissection. Fulguration, he will tell you the probe is held away from tissue. Okay, away from tissue, whatever, low amplitude and high voltage as well. So dissection and fulguration, both are high voltage, one low current or low amplitude, but the key in the exam will be in direct contact with tissue. You are doing dissection, here is away from tissue, so you are doing fulguration, like spray, like you are telling in operation, make it spray for me. Okay, go for cutting and coagulation. Sinusoidal, keep non-modulated. Wave 4. In coagulation, you'll find it modulated current with intermittent damped waves, high peak voltage, and so on. But the keyword for everyone, non-modulated will be cutting. Sinusoidal, non-modulated, it will come like this. Sinusoidal, non-modulated will be cutting. Modulated will be coagulation. Okay, indirect contact will be dissection. In away will be fulguration. Is it clear? Okay. Next question, Dr. Mumtaz, if you're back.
Yes, thank you. Can you hear me? Hello?
Yes.
Yes, you can hear me?
Yes. Yes, Dr. Mumtaz.
Okay.
Yes.
Okay, thank you. A 7-year-old boy is due to undergo a circumcision for phimosis. Which of the following devices would be the most appropriate agent to use for achieving hemostasis? Monopolar unit in cutting mode, bipolar unit, monopolar unit in coagulation mode, monopolar unit in blend mode, monopolar unit configured to spray mode. So we have to use bipolar unit. So all the others are monopolar. You cannot use them in the penis. So the answer is B, bipolar unit.
Okay, because it has in the artery and you can cause gangrene for the penis. So actually we use bipolar in circumcision, and sometimes some don't use any diathermy in dissection. Okay, Dr. Sarah, you want to participate?
Yeah, I want to ask a question, please.
Yes.
Sorry, I'm late. Why is it that monopolar units cannot be used on the penis?
Okay, you have first to know the difference between unipolar and bipolar. Okay. Keep it simply. Keep it simple is the difference between bipolar and unipolar.
Hello?
Okay, yes, I'm going to. Okay, the bipolar, you have electrode with two ends. With the electric current will pass. This is the two ends of the electrode. Okay, the electric current, you are this to the device. The electric current will be just between the two electrodes. Okay, so when you catch any point, you just have the electric current around this point only. Okay, this is the bipolar. You have two poles between your hands. Okay, and this decrease the spread of electric current through tissue. But what happened? In monopolar?
With monopolar?
In monopolar, yes, you have the electrode consists of one
electrode.
One side, one electron of the device, and you have to put another plate away. This is the patient, he's sleeping here, maybe this is his leg, and you have to put a plate to receive the current and don't go through the patient, or go through the patient through a special area or just a restricted area, but the current will go from the device through the other plate. So this is the current will go through the patient. Okay, and this carry a high risk sometimes of electrical injury. Electrical injury. That's why the plate of electrode has a special criteria has a special criteria to receive the whole current, and the patient shouldn't touch any metal beside him. So you can keep any infusion devices or any infusion portables and something like this, and you have to keep away. The plate should have some criteria, like should be at least 70 cm cubes, should be put in a muscular area away from bones, and should be put in a dry area away from hair, and should pass away from any, if you have any patient having like any internal
Pacemaker.
device like heart,
Yeah.
sorry,
Like, for example, pacemaker or cochlear implant.
pacemaker or cardiac valve or any metal, the current you have to make it should pass away from this pacemaker or from away this metal device. Okay, so now we are just using bipolar, trying to use bipolar as we can. So the current just between the two ends of the electrode, but the unipolar, you have one in your hand, other one in the patient, stuck to a muscular area from the patient, and the current you take pass through this patient. So if you are working in the appendix and you put the electrode on the thigh, so it passes from the place you are making the cutting till the electric current pass through the thigh of the patient, or it go through the thigh up to the other electrode of the diaphragm. Okay, this is the idea. The penis is just an end. The penis just has end arteries. If current pass through this artery and make coagulation of this artery, and we saw it many times, you will have gangrene for the penis. And the only solution for this problem is that you amputate the penis. So you can't use it in an end artery because it's a catastrophe to use a monopolar in especially in circumcision and the child and the very small vessels and very narrow blood vessels. So you can easily make thrombosis and coagulation of the vessel, and the patient can go through gangrene. Clear? Sorry, I have some chat. Can we use monopolar on forceps? No, طبعا. It's not recommended. Monopolar is monopolar. The body is part of the circuit. Exactly. Both of them, the body is part of the circuit, but not the whole body. This is between just the tissue, but this is the whole body. Yes, exactly, Dr. Baida. Not called monopolar on forceps. Is this the same as monopolar? Exactly. Okay, thank you. Let's go for the next question.
Thank you very much.
Okay, you're welcome. Okay, whose turn? Dr. Baida.
Okay. If it 2 by 2 centimeters of a locus skin graft is placed on area of a healthy granulation tissue, after about a week, thin bluish white margin appears around the graft and spread at a rate of 1 millimeter per day. What is it? Epidermis alone, epidermis and dermis, dermis alone, inflammatory exudate, fibrin. It's part of the normal tissue growth and wound healing by skin grafts. So it is epidermis alone.
This is epidermis alone. Okay, this is in the graph. The epidermis alone will start to peel at the margins, and this is a piece or just a start of a re-epithelialization process. Okay, this is re-epithelialization, epithelialization effect. The next one also about flaps and the graft. By the way, about questions about flaps and the graft, you have about 10 to 15 questions. It will be easy to remember. You will find some here and the others will be added from recalls. Okay, like we have last time, if you have a defect on the face or nose, okay, if it is small, you can use a rotational skin flap. If it is big and you can't close like rhomboid and very big, you can full thickness skin graft. You can use it from a smooth area like behind the ear and something like this. يلا, who's turn, Dr. Ali?
Yeah, 5-year-old suffer 20% burns to the torso. On examination, there's fixed pigmentation and the affected area has a white and dry appearance. Which of the following options represent the best management plan? Rotational microcutaneous flap, full thickness skin graft, excision and delayed primary closure, debridement and split thickness skin graft, excision and direct primary closure. I think this is a grade 3 burn, and we need have two options, either full thickness skin graft or debridement and split thickness skin graft. Yeah, I think this need debridement. Yeah, I'm going with the D.
You're going with D.
Yeah, because this
Yes?
is pigmentation and white. It's a grade 3, I think. So this need debridement at first, because this is the dead tissue and dead skin, and
Yes.
need, yeah, and split.
Exactly. You have dead skin, so you can't do a flap or make excision and leave it area, or make excision and nothing also called primary closure. So this you have to do a debridement for the patient, and a split thickness skin graft should be done over the affected area of burn. Okay, because it is a large area. So full thickness skin graft we don't put for burns, full thickness skin graft except with full thickness burn, and you have to remove all the skin, and you can do this. But here is the patient needs debridement, and you will put a split thickness skin graft. In burns, the question will come like this. In burns, you'll do debridement and you will put split thickness skin graft. Sometimes you know what, like meshing is also who is plastic. You know what is meshing of the graft to cover a large area. Okay. This is the difference between flaps and the grafts and where we can use it. I don't like to go for just pure study, because in question you will have more and more, and then when you understand it through the question, you can go back for the slides just to read the difference between them, because not all of this is required from us in our scope and our schedule. Okay, next, Dr. Abdul Qadir. دكتور عبد القادر اتفضل. Open your mic. Press the mic button. Press the mic. You are closing your mic, Dr. Abdul Qadir. Just open the mic.
Can I do this one off?
Okay, okay, Dr. Sarah, go.
Oh my God.
Dr. Sarah, go for the next question. Okay, Dr. Mumtaz, start again.
Okay, thank you. A 68-year-old man has a seborrheic wart on his left cheek. This is removed by use of curettage, leaving a superficial defect approximately 1 centimeter in diameter. What is the best course of action? Application of simple dressing, split thickness skin graft, full thickness skin graft, suturing of the wound with 2-0 nylon, rotational local flap. I think it is full thickness skin graft.
Full thickness.
Skin graft.
You have a seborrheic wart and you removed it using curettage. You just shave it.
Yeah.
So,
Oh, okay. So simple dressing. Yes, yes.
Yes,
Sorry,
you
it
shaved
should
it.
just
You
be
just
simple
shaving.
dressing.
You
Yeah,
use it.
yeah.
Yeah, the seborrheic wart, you make shaving. So
Yeah.
superficial, so re-epithelialization will happen. And this is just a 1 centimeter. So regular and normal re-epithelialization will happen for this patient.
Yes, yes.
Okay, you didn't remove any part of the skin. You just shave the wart. So it will
Okay.
be just application of a simple dressing. Father back. Okay.
Okay.
Okay, next question, Dr. Father. Tfaddal.
Thank you, sir. Which of the following method is most effective at destroying spores of the tubercle bacilli? Immersion in 0.5% chlorhexidine in alcohol, immersion in aqueous iodine, heating in hot air oven, immersion in 0.1% sodium hypochlorite, autoclaving. The answer should be autoclaving.
Yes, exactly. Spores of the
Yes.
tubercle will be
Okay.
only
By autoclaving.
by autoclave. Will be only by autoclave. Okay. This is the difference of sterilization, autoclave for reusable surgical equipment, and this maybe resemble most of our use in surgery. Okay. Glutaraldehyde, we have some questions about, and this will be about endoscopes and some laparoscopic equipment. Not all laparoscopic equipment, but we use endoscope, and some laparoscopic equipment we use glutaraldehyde.
2% glutaraldehyde. Yes.
Okay. Again, for suture materials, who's ready about this? Dr. Ghada, start again.
Which of the following is a permanent suture material best suited for interrupted mattress dermal closure? 2-0 polydioxone, 3-0 polydioxone, 4-0 polyglycolic acid, 1-0 dexone, 3-0 polyprolene. Either A or B. 2-0 polydioxone.
This is a permanent suture material, unabsorbable.
Permanent,
unabsorbable.
not absorbable. So polyprolene. 3-0
will be a proline.
or 1. Because it's the only permanent suture.
The only one is proline.
Yes, it's a permanent suture. The others not
Permanent suture.
permanent
Other PDS is not, and Dixon is not permanent. PDS is of about,
yes,
I think, 6 months, something like this.
12 weeks.
But proline is a
12 weeks.
permanent. Okay. Again,
Okay.
silk is biological, braided, and permanent. No, we don't use it for skin. We use it just, yeah.
Silk used for GIT, repair of intestine.
Second layer in the anastomosis, it's used for uncording drains, for skin closure.
Yeah, just
Yes.
we use it just for drains,
Chest tube.
just for drains, chest tube, and something. We don't use it anymore inside the abdomen. Before,
So
about
this is
maybe 10
shortcuts.
years ago, we were using it and ligating some vessels and ligating appendix, appendicular
Base of
base, and ligating
appendix.
cystic duct. All this was using
Stumps.
silk. Okay, in stump. But now
Yes.
silk, just use it for
Anchoring of drains.
yes. Catgut, forget about. Chromic catgut, forget about. You have no
Yes.
question. PDS.
Absolute.
PDS is very
Mast
important
closure.
now.
Any mast closure in the abdominal wound.
Yes,
that
we use
after
it.
laparotomy.
PDS is yes, and sometimes we use it in anastomosis, visceral anastomosis, and the closure of the abdominal wall. In mass closure of the abdominal wall, we use the PDS 1, or sometimes 2, or sometimes 1 or 2. Not we don't use 0 or 1 0 or something. We use a big one like 1 or 2, and this is a long, tough, absorbable suture material. Okay, monofilament. So you can use it in the abdominal wall and in visceral anastomosis. Okay.
Yes.
It is largely replaced Vicryl, by the way. Before we used Vicryl. Before we can closures of the abdominal wall, sometimes in adult person, we use Vicryl mixed with proline. You take one layer Vicryl together and one layer of proline, you can take it together, and this is an adult person, and then, but because Vicryl, it's about 35 days or 6 weeks, it's about at least 4 to 6 weeks to be dissolved, but that's why we were using proline layer with Vicryl closure of the abdominal wall. But now PDS replaced this. You'll find nothing maybe questioned about Vicryl, because now PDS is the upper hand. Proline is monofilament synthetic. We use it to close the skin sometimes, but we remove the sutures. This is permanent, and most important also for vascular anastomosis. Vascular anastomosis, yes, we use it the smallest one or the smallest size as we can, and this according to the size of the vessel, because it's less thrombogenic for the vessel, because it is less thrombogenic, put it in your mind, and with a very, very minimal reaction. So use it for vascular anastomosis. Also, we use it in cardiac surgery, closing the cardiac wall, and sometimes cardiac injury, like ventricular injury, atrial injury, mostly in ventricular injury. We use permanent, non-absorbable material like a proline in closing and suturing the cardiac wall. Okay. AC bond, we don't use it so much in our work. We use it, I think, in all my life. We just use it for large tendons, and used by orthopedic, like tendon Achilles and something like this, because it's very tough. Okay, synthetic, permanent. We use AC bond, and also at the same time it's expensive, and you will not have any question about. All question you will be have about this PDS and silk, and sometimes I don't think I maybe have one question about Vicryl, but proline is very important. PDS in most questions are very important, which is polydioxanone, and silk. We will find 1 or 2 questions about it. You have to know which one is permanent, which one is non-permanent, which one is monofilament, and which one is polyfilament. Okay, or braided. Next question. By that.
Okay. In which electrosurgical mode is the electrode held away from the tissue, where the current utilize a low amplitude and high voltage? It's fulguration, because desiccation is near the tissue, and cutting is amodulating, and coagulation is sinusoidal non-modulating. So it's B.
Perfect. I think it's easy now. Yeah. Just keyword, by the way, and in the exam, in my exam, I solved, I think, 2 questions about that term. It was the same like I tell you, like this. Okay. Next question. Okay. Dr. Sarah.
Okay. A 28-year-old man is undergoing an appendectomy for perforated appendicitis. What is the single most important modality for reducing the risk of postoperative wound infection? Perioperative administration of antibiotics, use of suction drain in the abdominal wall, use of passive drain in the abdomen, use of skin clamps for closure, and use of incise drips. Most modality. I think in preoperative antibiotics, admissive antibiotics is helpful in this case.
This is what type of operation is this?
Appendicectomy.
This is classification according to the clean or contaminated or clean contaminated, the risk of infection.
Is contaminated.
You can say contaminated. Sometimes now they say that clean contaminated because you are opening the GIT tract. Okay, clean contaminated. Sometimes contaminated if there is perforation or there is a pus and infection or suspicion of perforated appendix. But if it is just simple catarrh, it will be clean contaminated. In clean contaminated, if you go for part B, okay, you'll find when to give antibiotic for operations, and he tell you if you have a clean operation, you can give no antibiotic. Okay, and I have this policy, and I work with some doctors with this policy, and he in a clean operation, he just not give antibiotic, just give analgesic, like removal of lipoma if you have full sterilization. Okay, so from where you can get infection, you just give post-operative painkillers and just daily dressing. But in clean contaminated operations, they like to give 1 dose of antibiotic pre-operative. Okay, in contaminated operations, they sometimes like to give another dose post-operative. Okay, in dirty operations, I think 1 to 2 days post-operative. In contaminated operations, they up to maybe 5 days post-operative they can continue. You have a schedule about this, and you'll be asked in the procedure skills in part B about a case of removal of lipoma. He will ask you about the protocol of antibiotic. Okay. Next question, Dr. Ali.
Yes. During an open Watson fundoplication, the inferior wall of the spleen is injured, causing troublesome bleeding. What is the best course of action? Removal of the entire spleen, partial splenectomy, use of argon plasma coagulation system, sutured splenography, sutured ligation of the splenic hilar vessel. Actually, I don't have any idea about this question.
Will you remove whole spleen?
We said in a crush injury, if the spleen is crushed.
This is inferior pole of the spleen is injured. Okay.
Inferior pole of the
spleen. Some bleeding. Will you remove the spleen? If it is a case of splenic injury, and we do on CT and find a splenic injury, will you remove the spleen? You remember when we remove the spleen?
Yeah, I forget the question about the splenectomy.
Okay. If you have a hilar injury, or
hilar
you have
or vascular injury,
injury, or shattered spleen. Other than this, you will try as you can to preserve the spleen. So this is, you will not remove the entire spleen. You will not make partial splenectomy because you will make more injury and bigger wound. You will not suture the spleen or suture ligation, or you will not ligate the splenic hilar. So that means that you are going to do splenectomy by not going to suture the spleen. The only one here by exclusion, if you went for it, will be use of argon plasma coagulation system. Okay, you will not remove, you will not make partial removal, or you will not ligate the splenic hilum, or suture the spleen. You will make more injury. The only thing that you do for spleen, what's called splenic wrapping, and this is I think something advanced, and even I didn't see it before. They have some splenic injury and pool is just cutted or fissure. They do what is called splenic wrapping.
Yeah.
Okay, but for me, I didn't see before. Sometimes they wrap it with natural part of the omentum. Sometimes wrap with some synthetic, something like vicryl mesh or something like that to be dissolved in that time, stop bleeding. But for me, I didn't see it before. But the only solution here is argon plasma coagulation system.
Yeah.
Okay.
Okay.
Okay. Who's next? Dr. Abdul Qadir.
Okay.
Here or out?
Which
okay.
of the energy devices below would be most suited for resection of a parietal lobe tumor? Monopolar diathermy in coagulation mode, harmonic ACE, Cushar device, monopolar diathermy in cutting mode, ligation system. I think it's Cavitron ultrasound surgical aspiration device, Cushar device. C.
Exactly, because device we use it in brain surgery.
Okay.
As we said before, in brain surgery we use the Cushar system or Cushar device.
And Cushar device we also may be used in the liver resection also, CNS tumor and liver resection, I guess.
Yes, I think so. Yes, also. Okay.
Okay.
Level of evidence who's ready? Dr. Mumtaz again.
Okay. A group of surgeons review a meta-analysis of series of randomized controlled trials on the Cochrane database and decide that one type of hip replacement is superior to another. What level of evidence is this? It is level 1, because level 1 is the systematic review of several RCTs. This is level 1.
Exactly. Level 1. This is series and meta-analysis of randomized controlled trials. This is 1, and we said 2 will be only at least one probably designed randomized controlled trial. Okay, so to remember again level of evidence, I think you'll have 1 question or 2 questions in the exam about level of evidence. Okay. Number 1, all relevant randomized or meta-analysis. Here will be at least one probably designed. This will be pseudo randomized controlled trial, and this is the least one you'll have question in. You'll have this one and this one, and even this maybe not so. You'll have this one relevant, all relevant randomized controlled study, and then you go for 4 case study or case report or case series. This will be 4, and then your personal opinion will be level 5. You will have 1 question, by the way. It will be a very easy question in the exam. You shouldn't miss it. Okay, next question. Dr. Ghada.
You have just completed a laparotomy for peritonitis due to perforated peptic ulcer. What's the best surgical strategy for avoidance of complete abdominal wound dehiscence. Use of skin clips to close the skin. Okay, to close the skin more than the subcuticular sutures. Careful approximation of peritoneum with non-absorbable sutures. Mass closure of the midline wound using one polydactyl suture. Direct approach of rectus muscle rather than the linear elbow aponeurosis. Mass closure of the midline wound using 3-0 polyproline suture. I think it's a mass closure with one PDS suture. It's the best option.
You choose?
Using mass closure with one polydactyl suture.
Exactly. So you choose C. Yes,
Okay.
we do mass closure by one or two PDS.
Yes.
PDS is one of the most useful and nice suturing material to close the abdomen in mass material, and it's very long suture, by the way, and sometimes it comes in a name like loop. Okay, the loop will be a like
exactly
a double with one needle here, so it will help you in just making locking during your work. Okay.
Yes.
So protect against abdominal dehiscence by mass closure with one PDS. Dr. Baida.
Okay. 74-year-old male with colon cancer sustained an iatrogenic splenic injury during surgery. He is bleeding profusely. What is the most appropriate course of action? Infusion of human prothrombin complex, infusion of factor BC, infusion of blood from the cell saver, salvage during surgery, infusion of factor VIII, concentrate, infusion of gel fusion. I think it's a fusion of blood from the cell saver, salvage during surgery, to get benefit from the huge amount of blood that comes out from the
You choose
spleen. Okay, see.
C. You'll take cell saver in a cancer patient.
Sorry, I didn't. Okay, focus on the cancer. No, it's contraindicated, so we can infuse factor BC.
Exactly. Away from cancer, keep when you find something like this, a different infusion, and you find cell saver, go for the question to search about infection and about cancer. About cancer. Okay. So here you can't give cell savers salvage blood. You have to go for packed RBCs. Okay, concentrate about this, please, because you will have a question in the exam like this about cell saver and packed RBCs, and you want to know if you know to test if you know that cell saver salvage transfusion can go for patient with infection or cancer or not. You'll have the same question in the exam. Okay, next question. Dr. Sarah.
Which of the following is not an absorbable suture material? Nylon is unabsorbable. B. They have chromic catgut, vicryl and polydexanone. I'm going for B, that is nylon.
Okay. Which is not an absorbable material. And here is, I don't know why. He didn't say which of the following is non-absorbable. He is not an absorbable, so he have to confuse you. Keep in mind, by the way, in exam, in the stress of exam, you have 300 questions, 180 followed by 120. You have to read the heading and the scenario carefully, especially in scenarios with except all of the following, except which one is true, which one is false, except And you can find a question, which of the following is false according to this issue, and which is the following is false, or all of the following is false except concentrate. You will be in stress of exam. You have about 40 to 45 seconds for every question. I don't like to say 1 minute, just 40 seconds, because some question may take more than 1 minute, and you have to keep 10 or 15 minutes at the end of the exam just to revise your paper, your answer sheet, about that you have answered all questions. You have to make sure that you answered all questions in the answer sheet. Maybe sometimes you answer it in the paper and you forget to transfer it. This is a problem. The other problem, you have to have a white paper or a ruler or something dark to put it in the answer sheet and go step by step answering the question. And before answering the question, look again to the number of the question you are answering and start from the number and go for the same line with the paper down. Really confusing. You will find in the exam like this. I think every 5 questions they put it like this, and they are going like this in the exam. Okay. Five rules, and the paper is going like this. You have to put a white paper up like this and go down. This question number 30. You have to start here is 30 and go with the paper for your answer, and then go down, and then back again here. And you have to read this, because if you miss one rule, you just go for all this will be wrong. Reading the number of the question is very mandatory in the exam. It's really very small and confusing. And I know one of my friends who just missed one line, and he go for the rest of the questions by wrong, and he have to transfer it quickly, and he just have time to have another paper, and he just make a problem in Cairo and have another paper, and so quickly he just transferred the question and he passed, alhamdulillah. So please concentrate about the question, concentrate about the answer. You have to be sleeping well the day before the exam. Just revise few hours in the morning and then go for sleep. Please. Sleeping before the exam is very important. The 2 days before the exam, you should be relaxed, completely relaxed. The morning of the exam, you should be completely relaxed. It's about 6 hours with the break, or more than 6 hours sometimes. Okay, next. Dr. Ali?
Yes, a 73-year-old lady sustained distal radial fracture, and this is manipulated using pierce block with the brilocaine as the local anesthetic agent. During the procedure, the occlusion cuff deflates and the patient becomes progressively sinused. What is the treatment of choice? Intravenous calcium gluconate, exchange transfusion, intravenous methylene blue, intravenous sodium thiosulfate, intravenous gilofusine or gilofusine. We have here brilocaine toxicity, and the patient got sinused, and yeah. I'm going with the exchange now. I have to take antidotes, right?
Yes.
Yeah, intravenous methylene blue. Gel, no, sorry,
Saline
والله.
blue.
Yeah.
Exactly. Methylene blue. What about lignocaine toxicity?
Lignocaine
Intralipids.
and triped, yeah.
Interlipid. Okay, this is very important to know. Keep that Beres block you have 2 questions about. He will give you the type of anesthesia and ask you about the type of anesthetic agent. We have a question about this before, and sometimes gives you this, and they tell you have toxicity, and ask about the antidote. So here is block with prilocaine. It's very important because you can have the 2 questions, by the way. I think you'll have the both these questions will come in the exam for sure, 100%. 100% from one of the nice questions you like about anesthesia. They will ask you about the dose because you don't have many questions about anesthesia, but you have to give about 5-6 questions about anesthesia. So he likes to get the antidote, which is the methylene blue and the interlipid, and he likes Beres block. He likes so much. Even he will ask you about the type of anesthesia or the antidote for it. Very important question, by the way, about the anesthetic agents. It's very easy and very small, and this is questions that you have go for the exam. Make 100% that you'll answer all these questions. And the dose, I think we said about this last time. Next question. Dr. Abdul Qadir. Dr. Abdul Qadir. Dr. Mumtaz, start again, please.
Yes. A 72-year-old lady has a 4-centimeter basal cell carcinoma excised from her right cheek. There is a rhomboid defect measuring 4 centimeter by 4 centimeter. What is the best option for managing the wound? Delayed primary closure, direct primary closure, full thickness skin graft, split thickness skin graft, and myocutaneous flap. So the answer is full thickness skin graft.
Full thickness
Skin graft.
skin graft. Exactly. So we have 2 questions. Facial effects. Okay. One will use, this will be small, and most will be non-malignant, by the way, but it will be small, and you'll use a rotational flap. Okay. Rotational flap, sometimes it's called extension flap, sometimes it's rhomboid flap. Okay, this is a flap. We use it as extension from the near skin. We make some like undermining of the skin, and we use it. Okay, the other one is a large defect, and it will come in the exam like this: basal cell carcinoma, and you see it with safety margin 2 millimeter or 3 millimeter, something like this, or full thickness of the skin, and you'll have to get a full thickness skin graft, maybe from behind the ear, from the side, from a smooth thick skin, from a smooth skin, not hairy, to put it in the face. Okay, it will be full thickness. This is the 2, by the way, about the facial defects. One will be in the nose, lumbar flap, yes. One will be in the nose, mostly will be a rotational flap. The other one will be the cheek. You will put a full thickness graft. I'm just collecting questions that you'll face in the exam, by the way, and here while our.
Excuse me, can I give a note?
Yes.
How to differentiate when we use a flap and when we use skin graft? And as we say, because in case of BCC and squamous cell carcinoma also, we avoid using flap at the first time because we don't know if we have a safe margin. So we use a skin graft.
Yes.
In second point, in the first, there's exposure of cartilage. So it's preferred to use a flap to cover it.
Exactly, a flap, or if you have a big area over the cartilage, you can't get
Yes,
a rotational skin flap. You'll have to get a full thickness graft also.
but
We can. It will be small. Any small defect, you can make a flap.
yes.
Okay. If you work, I don't know if you worked before, like any plastic operation, you can, if you can find a redundant skin, maybe this is a face.
Should be not more than 1.5.
Yes, exactly, and you should find a redundant skin. You don't make tension for the skin. So if you have this face, and you have the cheeks, maybe old patient like this 30, not so old, and this one you have the cheek, and you have this one. Can you, by your hand, if you can extend it like this to cover, okay, without making attraction here on the skin or attention on the wound, by undermining the wound here and undermining, because you will approximate this and you will approximate this, you can make it extension flap or rotational flap or rhomboid flap or any extension flap,
Depending on the size.
advancement flap. But if it is you can't get a flap for this from this one, you have to get another flap maybe behind the ear. Most common we get it behind the ear and put it like full thickness skin graft here. Okay. By the way, now most operations in the face, especially skin cancer, the small skin cancer, done was by frozen section or Mohs operation, which can use it by frozen section, intraoperative frozen section, layer by layer, till he reach a clear slice from the skin, then start his closure. They don't wait for to find if the margin is clear or not, except for large operations or large defects.
A frozen section accepted in melanoma is avoided.
About what?
A frozen section, we should avoid it in melanoma because easily spreading it in the carcinogenic cells.
No, it is avoid to take incisional biopsy.
Yes, but excision. You prefer excision.
You'll excise it all.
Yes.
You'll excise it all, but you can do frozen section for the margin. And if you excise it all, you can do frozen section. It is contraindicated to take an incisional biopsy. But if you removed it all and you want to make sure that the margin is clear, intraoperative, you can do a frozen section.
Yes, except melanoma.
Except melanoma?
Except melanoma. It's contraindicated.
To do what?
Frozen section.
Frozen section?
Mm-hmm.
Okay, I make sure of this. But I think if you removed it with safety margin and you want to make sure that the margin is clear, intraoperatives, you can make it frozen section for the margin. If margins are clear, you can close. If margins are not clear, they can advance and wide local excision. Maybe. Okay. I'm not plastic surgeon, just to have questions according to the MRCS. Okay. Next question, who's Dr.?
Okay, a 43.
Okay.
A 43-year-old man has a symptom of carcinoid syndrome. Which of the following is the most effective therapeutic agent in controlling his symptoms? Atenolol, octreotide, glucagon, somatostatin, spironolactone. For carcinoid syndrome, octreotide.
Exactly. It's very famous, and we can find it even in, I think, in colorectal. We have the same question, I think so. Symptoms of carcinoid tumors, we use octreotide. You know, any, I think it's trade name.
Trade name.
Anyone can remember the trade? This is a synthetic somatostatin, by the way.
Yes. I don't know.
I think
Can't remember the
Senectine.
generic name.
Senectine, I think. Senectine of Novartis. It is Octreotide. I think
I'm not
Senectine.
sure. I'm not sure about the generic name.
I think Senectine. Anyone can search about it. Okay. Next question.
Which surgical energy device is most appropriate for performing sphincterectomy during ERCP? Monopolar diathermy device in cutting mode, bipolar diathermy, monopolar diathermy in coagulation mode, harmonic ACE, because I think it's monopolar diathermy device in cutting mode.
Exactly. We use monopolar, the surgeon, to use a cut. That's why sometimes happen bleeding during sphincterectomy. Okay, so cutting monopolar mode is needed to relax the sphincter of audience. This sometimes makes stone or any impacted stone to get dislodged by this sphincter. Next question. I think we answered it yesterday. Dr. Sarah?
Okay. A 24-year-old man is due to undergo an excision of a sebaceous cyst of his scalp. Which of the agents below should be used for local anesthesia? 1% lignocaine with 1 in 200,000 adrenaline, 1% lignocaine alone, 1% procaine, 0.5% bupivacaine, and then we have 0.25% bupivacaine plus 1 in 200,000 adrenaline. I think I'll go for 1% lignocaine with 1 in 200,000 adrenaline, but I'm not sure why though.
Why?
I'm not sure.
Anyone can tell us why?
I just remember two options. Lignocaine, either we put it in 100,000 or 200,000. This is to make, this is to not allow the, this is to make the lignocaine work longer. And with vasoconstriction also.
The scalp is highly vascular.
Here, we said yesterday in the first question, it was exactly when you have a highly vascular tissue, but not in the organ or in tissue, you can use with, and we give example, scalp. By the way, in the exam will be the scalp. The exam will ask about the scalp because it's a highly vascular and use. But sometimes use it when you're using mastectomy. Sometimes we inject, sometimes, and if you're doing accessory breast, or we are using, we are removing a lipoma. Sometimes we inject lignocaine with adrenaline to decrease the bleeding, and without is contraindicated in like fingers, toes, just in organs or extremities. In extremities, we just contraindicated to use adrenaline. Okay, this is the two question will ask you lignocaine with or without. In the scalp, you'll use with lignocaine. In the fingers, you use, or extremity, you use without lignocaine. So you have two advantage using lignocaine. You can increase the dose as you can, no problem. Lignocaine would be 7 milligram with adrenaline, and it will be only 3 without. And the second thing is it will go vasoconstriction and decrease the bleeding and increase the time for action. Okay, next question. Turn Also, thank Dr. Abdul Qadir. Okay, Dr. Mumtaz. Okay. Dr. Ali, it's your turn.
Yeah.
Okay.
Yes, maybe, I'm not sure. 43-year-old lady underwent an acute cholecystectomy for cholecystitis. A drain is left during the procedure. Over the next 5 days, the drain has been accumulated between 100 to 200 ml of bile per 24-hour period. What is the most appropriate course of action? Undertake laparotomy, arrange an abdominal CT scan, arrange an ERCP, arrange an abdominal ultrasound, order an erect X-ray, chest X-ray. Actually, I have two options. Either abdominal ultrasound or arrange an ERCP.
Okay. What do you expect?
We have, maybe we have, how can I say it? Maybe we make injury to the common bile duct.
No, maybe, yes, maybe.
Yeah, and maybe
you have injury, or maybe, but the most common, and this is a station part B, the most common if you find bile.
Or the eclipse is,
exactly, slip
yeah,
ligature or
slip ligature or eclipse, yeah.
Slipped club, okay.
Yeah.
Why you do ultrasound for this patient? The drain is your eye inside the abdomen.
Ultrasound
the drain,
is, yeah, we
the
have
drain
it
is
right,
your
so,
eye. You
yeah,
have a bile in a drain, so it's coming from the liver,
yes,
or the biliary system.
Yes.
And you have fluid. So you make ultrasound, see fluid. You will not see any fluid, by the way, by the ultrasound, because everything is get out by the drain. So the drain is your eye inside the abdomen for any collection. You do, and when you find abdominal distension and you don't, make sure you just go for ultrasound. If you find ultrasound there is collection, you go for CT to stand over the cause of this collection. But now you have the drain coming with bile. So the problem is coming mostly from the site of operation, which is the biliary system. And the best investigation for the biliary system is the ERCP.
The ERCP, yeah.
And it is diagnostic and
therapeutic
at the same time. If you find a leakage from the cystic duct stump, what will you do?
We have to do ligation.
ERCP, you are through the GIT, through the duodenum.
Stent.
How to ligate it?
Stent,
put a stent.
Yeah.
Put a stent.
Stent.
Very important to put a stent. Okay.
Yeah.
ERCP in surgery, we use it to put a stent in 2 occasions. If you have stricture, whatever malignant or post-operative due to excessive, excessive diathermy use, or like very close ligation, or suture material through the common bile duct and cystic duct, or the clip partially occludes the common bile duct and some narrowing, you just do a clip for widening. Or you have a cancer, like cancer of pancreas, or leak, as Dr. Adam, Dr. Baida said. Okay.
So it's also used to remove stone, right?
Yes, I'm talking about the stent, putting a stent.
Yeah.
Okay, putting the stent. Next question, laparoscopic surgery. Okay, Dr. Mumtaz again. Seeing Dr. Abdul Qadir left.
Yes. A 43-year-old lady is due to undergo a diagnostic laparoscopy. Which of the agents listed below should be used for inducing pneumoperitoneum? Argon, helium, air, carbon dioxide, nitrogen. It's carbon dioxide for pneumoperitoneum.
Yes, exactly. We use carbon dioxide for inflation of the abdomen. Okay, next question.
Which of the following Which of the following infection control modalities would be the standard practice for 53-year-old male undergoing a minor repair for parambilical hernia? Sodium hypochlorite solution applied to the skin, administration of clindamycin, aqueous iodine applied to the skin, administration of gentamicin, preoperative shaving. Standard. Well, povidone iodine, C, aqueous iodine applied to the skin, because the preoperative shaving increases the risk of infection, especially it's not the night before
Exactly.
the surgery. Sodium hypochlorite, I think, is not used for skin. And clindamycin or gentamicin,
It's not
for
used
his
for.
age, it's a clean surgery. There's no penetration to
No need for antibiotic for a clean
peritoneum.
operation. And this is Mayo's repair.
So,
You'll.
yes,
Sorry.
just extraperitoneal
This is Mayo
surgery.
repair.
So
You know Mayo
no
repair?
no role for
Yes.
antibiotic.
This
Yes.
is clean operation. You know Mayo repair, yeah?
So it's an extraperitoneal surgery. Yes, it's an
Extraperitoneal.
extraperitoneal procedure. So
No,
there's
I'm
no role for
asking about
antibiotic,
Mayo
no role.
repair. Mayo repair.
In general, no role for an elective.
Yes.
Yes,
Okay,
I know
so
about it, but I don't know how to explain it. Okay.
yes, okay. I just know. But if you ask some people, if they don't know what is Mayo
Okay.
repair, Mayo repair is okay. If he tell you, he will do.
Clean.
Sorry.
It's a
Bernstein
clean type of surgery. Hernia
or
in
he will
general.
put a
It's not.
hernioplasty. He just want to tell you it is a herniorrhaphy, not a hernioplasty. But if he said a hernioplasty, you have to give an antibiotic prophylactic. You have to know. That's why I'm asking. Mayo
Because
repair,
of
this is a
mesh.
herniorrhaphy. No mesh, herniorrhaphy, no mesh. So
Herniorrhaphy
no need
without
to
mesh application.
Okay, that's that I'm talking about.
Yes.
That I'm asking about. Okay, next question.
Okay. Which of the following sutures would be the most appropriate for securing a chest drain following Telocatum? 20 self, 40 self, 1 proline, 1 proline, 10 proline, and 30 Vicryl. 20 self.
Exactly. We use silk. What he wants to know, you'll use big one or small one. 40 can't fix chest drain, can be torn easy. So you can use a 20 silk outside the body for drain fixation. Okay, next one. Next question. Dr. Sarah. Dr. Sarah. Dr. Ali.
Yeah, I'm here.
Okay.
A 75-year-old man undergoes a Hartmann procedure for sigmoid diverticular diseases with pericolic abscess and colovesical fistula. What type of drain should be inserted following this procedure? T-tube drain, Wallace-Robinson's drain, Radivec drain, regurgitated drain, no drain. Regurgitated, corrugated drain rather.
Corrugated drain, historical drain.
Hello?
Yes, sometimes you historical
Might be hard.
drain. Sorry, maybe.
I think it's maybe corrugated drain.
Corrugated?
Drain.
No. It's a historical drain, corrugated drain, and sometimes use it for subcutaneous only. We don't put it inside the abdomen.
Okay.
So we use T-tube. What we use T-tube for?
Yeah, I think we can use T-tube to make intra-abdominal drain.
Anyone has some answer? Okay, let's help each other in this. I know this is pure surgical.
T-tube in gallbladder.
T-tube in CPD.
common bile duct.
Yeah. CBD exploration, we use T-tube.
Radivacum
And
in thyroid surgery.
Thyroid and breast surgery.
Thyroid
High
and breast
pressure.
surgery, negative pressure, and corrugated drains is historical, and no drain, no, it's not accepted. So we do Wallace Robinson drain. It's just non-suction drain. We use just a simple drain.
As we deal with mesentery, so we avoid high pressure or suction because goes
Yes,
necrosis.
it will be. Yes, maybe because some ischemia, some injury, and it will be blocked as you go through the abdomen. Fistula, maybe injury also.
Question.
Next question, Dr. Ali.
Yeah, you are specialist trainee asked to review a 39-year-old man post-gastrectomy for bleeding duodenal ulcer. He's hypotensive and tachycardic. His drain has an increased output, contain pus, and has bubbles. There is excoriated skin around the drain sites. What is the explanation for this presentation? Distal enterocutaneous fistula, superficial wound infection, proximal enterocutaneous fistula, enteric fistula, colocutaneous fistula. Yeah, we have fistula here, and let me see which kind of fistula we have. The gastrectomy for ulcer, hypotensive, and contain pus and bubbles. I think I'm going with the bubbles is come air, so it's with the skin, so it's coming with the enterocutaneous. But if it is proximal or distal,
it's a gastrectomy operation.
Yeah. I'm not sure, really.
Proximal.
Yeah, it's
Proximal before ligament of the trace.
This is gastrectomy.
Yeah, proximal.
Gastrectomy, so it is proximal.
Proximal,
So
yes.
the patient is toxic. The patient has signs of leakage, hypotensive, tachycardic, postoperative, post-gastrectomy, and you have to doubt leakage. And the patient is with drains, so the drain contains pus and bubbles and increased output. So it is confirmed this is your eye inside. If the patient has no drain, you can just find tachycardia and hypotension and fever. This is starting of leakage or septic shock. Okay, but here you have a drain as the drain containing pus and increased output, and around the drain skin is excoriated. So this is all signs of leakage or signs of fistula. So if you find this away around the wound, so it is enterocutaneous fistula, and this is proximal because this is a gastrectomy operation. Okay, distal fistula will be more and the ileum or something like this, ileum lead or last part of the lesion. Okay, next question. Forget about studies now. We'll go for it in management. Okay, next one. دكتور عبد القادر برضه مش موجود. دكتور ممتاز again. دكتور عبد القادر موجود. Okay, Dr. Mumtaz.
Okay. A 72-year-old man has discharged from a healed abdominoperineal resection wound. On examination, it has almost completely healed, but there is a prominent granulation tissue at the apex of the wound. There is no evidence of an underlying collection and he is otherwise well. What is the best course of action? Excision of the area, cryotherapy, application of topical silver nitrate, compression dressings, and application of alginate dressings. So the answer is application of topical silver nitrate.
Okay, exactly. This is a small granulation tissue or a small granuloma post-operative in the skin. Sometimes we find it, especially in surgeries under tension. Just make it application of topical silver nitrate for ablation of this granulation tissue. Okay, next.
A 19-year-old male presents with axillary lymphadenopathy and symptoms suggestive of Hodgkin lymphoma. What's the most appropriate investigation? Fine needle aspiration of the lymph nodes, freehand needle core biopsy of lymph nodes, image-guided core biopsy of lymph nodes, excisional biopsy of lymph nodes, or axillary node clearance. It's not axillary node clearance, neither image-guided biopsy, neither core biopsy. It's either FNA or excisional biopsy. I think excisional biopsy, because there's suggestion of malignancy. So number 4, excisional
Not
biopsy.
this is a
of
protocol for
breast.
lymphoma. Protocol for lymphoma in breast without.
Yes.
Okay, the rule and lymph node take
Yes.
a fine needle aspiration cytology. Okay,
I think
but
only in thyroid we use.
And even in cancers, if you doubt cancer, if your patient has a mass, a breast lump, and you can palpate an
Yes, in
axillary lymph
cancer.
node, you go for fine needle aspiration. If it is negative, it's okay. If it is positive, you will go for axillary lymph node clearance.
Yes.
Okay, so here, but the policy and the protocol in Hodgkin lymphoma or suggest Hodgkin lymphoma, you have to take a full lymph node by excisional biopsy for analysis.
Excisional biopsy.
Excisional biopsy.
Okay.
Okay, you'll take a complete lymph node.
Yes.
Next question.
Okay. What is the mechanism of action of suprafloxacin? Inhibition DNA gyrase, direct injury to bacterial cell wall, osmotic damage to the cell, inhibition of reverse transcriptase, destruction of bacterial aquaporin proteins. The suprafloxacin is inhibition of DNA gyrase.
Exactly, this pharma question. Yes.
Because bacterial cell walls act on penicillin, and
yes, we'll discuss this all here, and we make an easy way to know it. Okay. Very easy here. I like to start from this. RNA only rifampicin. Okay. DNA, most of them are cocktails we use in gastroenteritis. Sometimes we use Cepro plus metronidazole or sulfonamide trimethoprim, which is like Septrine, which is called Septrine. We use it, which is sulfonamide plus trimethoprim, and this quinolone plus metronidazole. I think in the market it was some cocktail like this. So DNA, quinolones or Cepro and metronidazole, this regimen for gastroenteritis, and they couple sulfonamide trimethoprim, which is called sulfamethoxazole or Septrine in the market. Okay, this according to RNA and DNA. Finish about. Go for cell wall, which we know that's penicillin and cephalosporin. First two groups discovered. Okay, cell wall, just penicillin and cephalosporins. Then protein senses, otherwise aminoglycosides, chloramphenicol, macrolide, tetraglycine, and so on. But the most important, RNA rifampicin, DNA quinolone, metronidazole, trimethoprim, sulfamethoxazole. Okay, and cell wall is only penicillin and cephalosporins, and the others will be inhibit the protein senses. Okay, which is aminoglycosides, macrolides, chloramphenicol, tetracycline, and fusidic acid. Easy to know, okay? Great. Next question. Dr. Sarah.
A 73-year-old lady with gallstones is about to undergo a laparoscopic cholecystectomy. The surgeon inserted a varus nodule and performed a successful drop test prior to establishing a pneumoperitoneum. A 5 minutes later ensures before a 10 mm infraumbilical trocar is inserted. Surgeon performed a diagnostic laparoscopy which shows a thickening gallbladder, but is otherwise normal. The anesthetic complains that the patient has become hypertensive with a blood pressure of 80 on 40 mm mercury. Of the options below, which is the most appropriate course of action? Release of pneumoperitoneum, perform laparotomy, administration of peritoneous adrenaline, administration of intravenous amiodarant, and the operations. Release of pneumoperitoneum. That's what I think is the release of pneumoperitoneum.
Exactly. What do you expect that happened?
Confinement syndrome of the abdomen, because there is excess of the air that causes the low blood pressure. Somebody said
Exactly.
decrease in venous return.
Increase intra-abdominal pressure.
Mm-hmm.
Increase the intra-abdominal pressure, which decreases the venous return.
The venous
We
return.
abolish complete abolish of the negative intra-abdominal pressure that helps the venous return with the we make a very high pressure that abolish and decrease the venous return. Okay, decrease the venous return, we'll go the patient in something like hypovolemic shock. Okay, so you instantly, if the anesthetist tell you the patient starts to be hypotensive, instantly decompress and release the pneumoperitoneum. Anyone can know what is the range of pneumoperitoneum if we make it for patients for laparoscopic surgery? Seven to 15. No, you can't do an operation like this. $15 to $20, so not more than 20, no. Okay, almost we go from, it's about 14, 15, something like this. No, not 7. 7 you can't, yes, 7 to 15 is the intracranial pressure. You can't do an operation. You can do an operation with 7, okay? This is from, no, sometimes it's normal we do it from,
10 to
here
20?
I did see it, no, 10 to 15 maximum. And we always use it 14, 15 in operations, 14, 15. This is the range. Up to, during the operation, it comes to 12, then comes again for 20, for 13, 14, but we try to keep it at 14. 15 maximum, but more than 15 knots, very dangerous for the patient. Okay. Sometimes it's 16 or something, but more than no, more 15. 15 is the maximum, mostly the most patient. Okay, who's next?
I think my. Yeah.
Yes. Okay.
Okay. Which of the following is least likely to reduce the risk of postoperative wound infection? Calcitrical clipper to remove the body hair, use of what is that? Providone?
Providone. Providone impregnated
yeah.
drops.
Impregnated drapes, and antibiotic prophylaxis for prosthetic placement, routine use of mechanical bowel preparation, chlorhexidine to prepare the skin. Yeah, chlorhexidine is right. Antibiotic prophylaxis is right also. Use of povidone impregnated drapes is right. And hair clipper, electrical hair clipper is also right. So by exclusion, routine use of mechanical bowel preparation.
Yes. Now it is rarely used. Yeah. Not routine, exactly. We don't use it as routine. Okay. So others, and even by exclusion, others can reduce. It's least likely to reduce, but others reduce. Use electrical clipper, yes. Povidone, iodine impregnated drops, yes. Antibiotic prophylaxis for any procedures, yes. And chlorhexidine for the skin. All of these can decrease the post-operative risk of wound infection, except for routine bowel preparation. Next question, Dr. Mumtaz.
A 67-year-old woman is undergoing a femoral hernia repair, and the surgeon is using a bipolar diathermy unit for hemostasis. Which of the following is a recognized risk in the use of bipolar diathermy? Patient burns at the site of the contact plate, fires when used near alcoholic skin preparations that have pooled, coupling injuries, risk of thermal injury to regional vessels as a result of tissue heating and capacitance injuries. Okay. It's fires when used near alcoholic skin preparations that have pooled, because all the others are due to the monopolar, and this is due to bipolar.
Yes, patient burn at site for contact of the plate, the same like coupling injury, capacitance injuries, and risk of thermal injury at regional vessel as a result of tissue heating. So the only one is fire when used near alcoholic skin preparation. Okay, next question. Dr. Ghada. Dr. Ghada. Dr. Baida.
Okay. 34-year-old lady is due to undergo a laparoscopic cholecystectomy. Which of the following intra-abdominal pressure should typically be set on gas insufflation system? As we say previously, is 10 millimeter.
10 to 14, 15 maximum. Yes, exactly. 10 to 14, 15. Yes, here is set in between 12 to 15. Or yes, 12 to 15. So 10 here is the best answer. Level of evidence again. Who's next? Dr. Ghada back. Okay, Dr. Ali. Dr. Sarah.
Okay. A group of surgeons are trying to decide which type of mesh to use for incisional hernia repair. Their assimilated evidence includes 2 cases series and a non-randomized controlled trial. Which level of evidence is this? Level 3, level 1, 4, 2, and 5. Level 2. Not sure
Level?
what is level 2.
Level 2, why?
I think so. I don't know. I guess.
Okay, we solved many questions about it. Okay, here he won't just confuse you. Okay, we tell you 2 series, so you want to go for 4 2 case series, but he has and 1 randomized control study. So you have a higher study than this. It will cancel this, and you will depend in the end on 1 randomized control study with each 2, and we said that first one, all studies will be one, at least one will be 2, pseudo-randomized will be 3, and then 4 will be case series, and 5 will be your personal idea, your personal decision. So it will be 2, as we said.
Okay.
Okay, next, Dr. Ali.
Yes, 53-year-old man undergo an elective right hemicolectomy. Stabled ileocolic anastomosis is constructed. 8 hours later, he becomes tachycardic and passes approximately 600 ml of dark red blood per rectum. Which of the following process is the most likely explanation for this occurrence? Anastomotic leak, discharge mesenteric hematoma, bleeding peptic ulcer, anastomotic stable line bleeding, mesenteric infarct. We use a stablet, so this is anastomotic stablet line bleeding.
Anastomotic
Yeah,
staple
stablet
bleeding.
line bleeding, yeah.
By exclusion.
Yeah, because this
is
we
not
don't have
anastomotic leak.
No, not discharging.
This is not
from,
anastomotic leak. No discharge. Yeah. This is a dark blood.
Yeah.
Dark blood. Keep this dark blood.
Yeah.
Discharge mesenteric hematoma. No.
No.
Bleeding. No.
Peptic ulcer. No.
We are away from peptic ulcer.
Yeah.
Mesenteric infarction will give us dark. Will be fresh blood, by the way.
Yeah.
Fresh blood. If you have infarction, the patient will pass diarrhea with fresh blood. So it will be anastomotic stablet line bleeding that happens post-operative. Next question. Okay, Dr. Mumtaz.
Yes. Which of the following sutures is most suitable for the mass closure of an abdominal wall following a laparotomy? 1 polydioxanone, 1 0 polydioxanone, 2 0 polydioxanone, 1 0 silk, 1 0 polyglactin. So it should be 1 polydioxanone, not 1 0 2 0.
Yes, PDS. 1 PDS. Polydioxanone 1. We have used it many times in closure of abdominal wall, in protect against abdominal dehiscence, and this is absorbable after a long time. So PDS in the abdominal wall closure and in anastomosis, in intestinal anastomosis. Okay, but in intestinal anastomosis we use 3-0 or something 4-0, something like this. Okay, who's next? Dr. Ghada. Dr. Ghada. Out. Dr. Baida.
Okay. In which electrosurgical modality does a sinusoidal non-modulating waveform resulting in vaporization of the tissue?
Okay.
From
the first and second word.
Cutting is correct. Cutting correct.
Cutting.
B.
We said sinusoidal, non-modulated, cutting, modulated, coagulation, indirect to the tissue will be dissection, in away from the tissue will be, both of them with high voltage, will be fulguration. I think it's easy now about the questions about the dissect, the diesel discernment. Yeah, I think it's very clear now. We can know it from the first word. It will get like the sinusoidal, non-modulated, modulated, indirect with tissue, and away from tissue. This is very important keywords you have to say in any scenario, so you make sure this is your answer. Yes, thanks. We finished.
Okay.
Thank you. We now finished all surgical techniques and technology. I think we may have one session only and we finish paper 2. This is the rest of management session. We'll start with Dr. Salah about some statistics, and it's maybe just silly session, and you have about 5 questions in the exam. Most of them, or 6 questions, something like this. Most questions will be about consent, and easy question, one about the mean and median, and maybe 1 or 2 questions about the type of study. I'll try to prepare it all together with the I think we have hand surgery, hand disorders also we didn't finish yet. But it's about less than half an hour session. I don't think it's more than 20 questions, something like this. Okay. Yes, I said hand disorders, really. I know, Ajay, Lucia, you are waiting for hand disorders. This is about 10 questions. I can send PDF, and no need for Zoom discussion for hand disorders. Okay, so hand disorders and some management issue and the statistics we didn't solve, and we will finish paper 2 and then go back to study again paper 1, and then again we didn't do pathology, but I always prefer to do pathology, or we will solve pathology after you solve all or revise all surgical specialties. So pathology will be very easy because more than 50% will be repeated again. Okay, thank you again. I'll close the record.